Welcome to Lesion Localization in Neurology Essentials. This is David Lee Gordon, Professor of Neurology. The learning objectives for lesion localization in neurology are 1, to localize lesions based on clinical presentation, that's history and exam, to one of the 10 clinical neuroanatomical regions, the 5 central nervous system and the 5 peripheral nervous system locations, and to determine the most likely etiology of a neurologic lesion based on its localization. The 10 main areas in the nervous system include, in the central nervous system, cerebral cortex, cerebral subcortex, brainstem, cerebellum, and spinal cord. And in the peripheral nervous system are nerve root or cranial nerve plexus, peripheral nerve or cranial nerve, neuromuscular junction or sensory end organ such as eye and ear, and the muscle. Lesion localization is an essential early step to diagnosing neurologic disease, and one should always follow the SADE or SAID process in order. Syndrome. First translate the chief concern into a syndrome or multiple syndromes. Anatomy. Localize lesions for each syndrome. Diagnoses. Determine the possible medical conditions for each anatomic location, and etiologies. Determine the possible etiologies of each possible diagnosis. The next few slides present an overview of the central nervous system, progressing from rostral to caudal direction, from the top of the head to the bottom of the spinal cord. On this slide, we see the cerebrum consists of the cortex, the outer part, and the subcortex underneath it. Beneath the cerebrum is the brainstem, consisting of 3 areas: the midbrain, the pons, and the medulla. Behind the brainstem and underneath the cerebrum lies the cerebellum. Caudal to the brainstem is the spinal cord with its 4 regions: cervical, thoracic, lumbar, and sacral. Here, the 4 main areas of the central nervous system, the cerebrum, brainstem, cerebellum, and spinal cord, are all labeled on one slide. The central nervous system, or CNS, requires protection from external trauma. The cranium, or skull, is a hard container enclosing the brain made of bone. The meninges are a 3-layered sac surrounding the brain and spinal cord, lined with pain nerves. The 3 components are the pia, the inner layer, the arachnoid, or middle layer, and the dura mater, or outer layer. The vertebral column, or spine, is a hard, flexible container that protects the spinal cord, made of individual bones or vertebrae, stacked on each other and separated by spongy discs. Now, although the cranium, meninges, and vertebral column form a rigid container that protects the CNS from external trauma, they also make the CNS susceptible to internal compression from pathologic processes. Localizing a lesion in neurology is very similar to playing 3D Battleship or locating a place on a map. There are wires going horizontally and wires going vertically. On this slide, we see the horizontal wires. In the cerebral cortex, the cognitive functions, attention on the right and language on the left, the visual pathways on either side, and gaze control, control of the direction that you're looking in, is all up in the cerebrum. In the brainstem, you have cranial nerves and horizontal gaze control that are horizontal wires, as it were. In the cervical spinal cord, you have cervical nerve roots. Then more caudally, thoracic nerve roots, then more caudally lumbar nerve roots, and then sacral nerve roots. The vertical wiring in the central nervous system are called long tracts, and they include motor pathways, sensory pathways, and cerebellar pathways. The motor pathways coming from the frontal cortex include the cortical bulbar tract, which synapse in the brainstem on cranial nerves, and the cortical spinal tract, which synapse on the anterior horn cells in the nerve roots in the spinal cord. The sensory pathways coming from the limbs and body up to the brain include the spinothalamic tract, which carries pain and temperature sensation, the posterior dorsal columns, which carry vibration and proprioception in the spinal cord, and then continue on up the medial meniscus, which carries vibration and proprioception in the brainstem. Here is a look at the complete map with horizontal and vertical wiring, as it were, in the central nervous system. This slide shows the vertical and horizontal findings for lesions in the central nervous system. The vertical findings involve the long tracts. A patient with a lesion in the motor pathway will result in weakness on one side of the body, called hemiparesis. A lesion in a sensory pathway will lead to hemisensory loss, sensory deficit on one side of the body, and a lesion in the cerebellar pathway will lead to hemiataxia, ataxia or lack of coordination on one side of the body. The horizontal findings from rostral to caudal include the cortical findings of visual field deficit, aphasia in the dominant hemisphere, neglect in the non-dominant hemisphere, and gaze preference, sometimes referred together by the acronym VAN with a silent G. In the subcortex, there are no horizontal findings, only long tract findings. In the brainstem, there are cranial nerve findings, so double vision or diplopia, gaze palsy, and vertigo are common symptoms with lesions there. And the horizontal finding in the spinal cord are those of nerve root abnormalities or radiculopathies. Upper motor neurons are first-order neurons completely in the CNS. The cell bodies are in the cerebral cortex in the frontal lobe, and they travel in the pyramidal tract, which includes both the cortical bulbar and cortical spinal tracts. They then synapse on the lower motor neuron in the brainstem for cortical bulbar tract, or spinal cord, anterior horn specifically, for the cortical spinal tracts. Lower motor neurons are second-order neurons. They start in the CNS but end in the peripheral nervous system. The cell bodies are in the brainstem and spinal cord, anterior horn specifically in the spinal cord, and travel in the cranial nerves and spinal nerves via the ventral roots. They innervate skeletal muscle. The limb weakness patterns are different for upper and lower motor neuron deficits. Upper motor neuron lesions result in increased tone or spasticity, increased reflexes, hyperreflexia, and a Babinski sign. The lower motor neuron lesions lead to decreased tone or flaccidity and decreased reflexes or hyporeflexia and an absent Babinski sign. When a lower motor neuron lesion has been present long enough, there is atrophy of the muscle and the presence of fasciculations that you can see on exam and fibrillations that can be seen only on an electromyography or EMG test. In general, muscles are irritable when they're not attached to a lower motor neuron. So one way to think about this, as long as the lower motor neuron is intact, there's no atrophy, fasciculations, or fibrillations. But as soon as you damage the lower motor neuron, the muscle doesn't like it. It gets irritable and gets smaller. Acutely, in the first few days, minutes to days, the tone and reflexes may be decreased in CNS lesions, but they will later become increased. Upper and lower motor neuron lesions, the facial muscles present differently. Let's first look at the normal facial strength exam. In the cartoon on the left, observing a patient at rest, Look at the frontalis muscles in the forehead, the palpebral fissures, or the openings of the eyes, the nasolabial folds, the creases from the nose to the outer mouth, and the mouth itself. When asking a patient to smile, look to see if the mouth upturns equally on both sides and the nasolabial folds increase their crease or depth symmetrically bilaterally. When asking a patient to raise your eyebrows, look at the forehead muscles, the frontalis, and make sure they go up equally and crease the forehead equally on both sides. And in response to asking a patient to close your eyes tightly, you can tell if the eye is closed tightly when, or the bicularis oculi muscle is completely contracted, when the eyelashes are elevated. In other words, going from perpendicular to the ground to horizontal to the ground when sitting up. In an upper motor neuron or central left facial weakness in which the lesion is in the contralateral brain or brainstem above the mid-pons, note that the patient will have a flattened nasolabial fold and a slightly widened palpebral fissure contralateral to the lesion at rest. When asked to smile, the nasolabial fold asymmetry is more pronounced and the smile is asymmetric with a so-called drooping of the face that's weak. When asking the patient to raise the eyebrows, there should be normal contraction of the frontalis muscles, and the patient is able to elevate the brow equally on both sides. When asking the patient to close eyes tightly, usually there is mild weak eye closure weakness, and the eyelashes don't fully elevate. In a lower motor neuron or peripheral left facial weakness involving the ipsilateral facial nerve or cranial nerve 7, there's also a flat nasolabial fold, but it's on the side of the lesion, and the palpebral fissure is particularly wide, wider typically than in the central facial weakness. When asking a patient to smile, the nasolabial fold discrepancy and asymmetric smile are again present with a so-called droop again of that face that's weak. The big difference between the lower motor neuron and upper motor neuron weakness is in the eyebrows. When asking a patient to elevate the brow, the lower motor neuron lesion or peripheral facial weakness will result in an inability to elevate the brow on the side of the lesion, whereas the unaffected side, the contralateral side, will have normal eyebrow raising and wrinkling of the forehead. When asking a patient to close their eyes tightly, the patients with lower motor neuron weakness of the face have profound eye closure difficulty, much more than with upper motor neuron lesions. There are also different upper and lower motor neuron patterns of neurogenic bladder. Parasympathetic dysfunction with detrusor sphincter dyssynergia may occur due to both upper motor neuron and lower motor neuron lesions. Dyssynergia means not working together. DYS, abnormal synergy, abnormal synergy between the detrusor, the main muscle of the bladder, and the sphincter of the bladder. In an upper motor neuron neurogenic bladder, the lesion is anywhere between the pons and the sacral spinal cord. And in this case, the upper motor neuron refers to parasympathetic motor cells with nuclei in the pons. The most common cause is a myelopathy of some sort, something involving the spinal cord. In this case, the bladder is small and spastic, hypertonic. And the symptoms are urgency, hesitancy, frequency, and small volumes. In a lower motor neuron neurogenic bladder, the lesion is anywhere from the sacral nerve roots to the peripheral nerves, and the causes are spinal stenosis, mononeuropathy multiplex, chronic meningitis, and other pathologies that affect these sacral nerve roots. In lower motor neuron neurogenic bladder, the bladder is large and flaccid, hypotonic, and the symptoms are overflow incontinence or dribbling. In this image of the brain seen from a coronal view, that is, say, facing the patient, we see the four main areas: the cerebral cortex, the cerebral subcortex, the brainstem, and the cerebellum. The cerebral cortex, the outer layer of the cerebrum, is made of gray matter, densely packed neuronal nuclei. And it is a computer center, the center for reasoning or voluntary movements or voluntary activities. In general, the front part of the cerebral cortex, the anterior part, has motor functions, and in general, the back part of the brain, the cerebrum, has sensory functions. In most people, the left side of the brain has the language center, and the right side of the brain has the attention center. And there are 5 main zones of the cerebral cortex: the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe, and insula. Underneath the cortex is the cerebral subcortex, which is composed mainly of deep white matter wires. Deep white matter is myelinated axons, they're connecting different neurons, and gray matter balls, if you will. And there are 2 major types of these gray matter balls: the motor modifier balls, basal ganglia, and the sensory consciousness relay station, or thalami, thalamus singular, thalami plural. Beneath, or caudal to the brain, the cerebrum, is the brainstem. And the brainstem is the funnel or connector between the cerebrum and the spinal cord. It also has wires to the face and head, so-called cranial nerves, as well as primitive centers, such as for breathing and consciousness and etc. And behind the brainstem and beneath the cerebrum is the cerebellum, which is a coordination center, coordinating muscle movements, making different muscles talk to each other so you have coordinated movements. This is the same coronal view of the brain with a little more detail. So one can see that the cerebral cortex in the frontoparietal area especially is divided into control of different parts of the body. The lateral part of the frontoparietal cortex is face, the superior lateral is arm, and the medial is leg. And in the subcortex, the basal ganglia consists of the caudate nucleus and the lentiform nucleus together. You also have the deep white matter and thalamus there. And then in the brainstem, the 3 components are midbrain, pons, and medulla. Looking at the cerebral cortex in more detail and its 5 zones with their functions, recall that the front of the brain is more involved with motor activities and the back of the brain is more involved with sensory activities. And specifically by front, we mean the frontal lobe, which is the center for reasoning, motor activity, and motor speech, especially on the left side of the brain. The parietal lobe, more posterior, is involved with sensation, sensory speech on the left side of the brain, inferior visual field control, and attention on the right side of the brain. And the temporal lobe, which is inferior and posterior, is involved with auditory activities, sensory speech if it's on the left of the brain, left cerebrum, superior visual field, and memory and emotions. And the occipital lobe in the far back is involved with vision. The insula, which is tucked inside that Sylvian fissure, not seen on the sagittal view, but seen only on the coronal view there, is right next to the hypothalamus and is very involved with autonomic nervous system control and also, like the temporal lobe, involved with emotions. As stated earlier, the acronym VAN, or the silent G, is used to identify clinical findings from the cerebral cortex. V, visual field deficit, refers to a homonymous visual field deficit. This is decreased vision to one side in both eyes due to dysfunction behind the optic chiasm in the parietal, temporal, or occipital lobe. Aphasia, A, is a language abnormality due to focal dysfunction in the dominant hemisphere in the frontal, parietal, or temporal lobes. Usually the dominant hemisphere is the left hemisphere. And neglect, N, is lack of attention to one side, usually the left, because in most people, the control of attention is in the right hemisphere, the focal dysfunction in the non-dominant or right parietal lobe. And G stands for gaze preference, especially horizontal gaze preference, deviation of both eyes to one direction and lack of volitional control of eye movements due to focal dysfunction of the frontal lobe. gaze, movement of the eyes, is a motor activity. Therefore, it's in the frontal lobe. To be Van positive means to have hemiparesis plus any of these Van findings. If acute, it suggests an ischemic stroke due to occlusion of a proximal middle cerebral artery, so called the M1 segment, and therefore the patient might be eligible for thrombectomy. Looking more in depth at the Van components in the visual fields, cortical lesions are behind the chiasm and produce homonymous deficits, meaning they're the same in both eyes. Looking at the pathways on the left and comparing them to the visual field deficits on the right, if a lesion is in the parietal radiation plus temporal radiation, one has a hemianopsia on the other side. If someone has a lesion in both the superior and inferior occiput, you also have the same hemianopsia. When a lesion is in the temporal radiation inferior to the parietal lobe, you have a superior quadrantenopsia on the other side, and the inferior occiput on that side would give you the same superior quadrantenopsia. And when you have a lesion in the parietal radiation, which is superior to the temporal lobe, you have an inferior quadrantenopsia. And likewise, a superior occipital lesion would give you an inferior quadrantenopsia on the other side. The next component of Van is aphasia, and there are two types, expressive and receptive. Expressive aphasia is poor expression or difficulty getting out words. The frontal lobe creates spontaneous language and expresses it via the Broca area in the posterior aspect of the inferior frontal gyrus. The Broca area is conveniently located near the face and hand motor cortex in the frontal lobe, facilitating expression via writing or speaking. Expressive aphasias are also known as anterior aphasias or motor aphasias, and logically are often associated with motor deficit, such as weakness on the other side of the body. Receptive aphasia is poor reception or difficulty understanding words. The Wernicke area in the posterior aspect of the superior temporal gyrus receives language and distributes information to temporal and parietal lobes for comprehension. The Wernicke area is conveniently located adjacent to the auditory cortex in the temporal lobe and near the visual cortex in the occipital lobe, facilitating receiving language via hearing or reading. Receptive aphasias are also known as posterior or sensory aphasias, and again, logically, are often associated with sensory deficits, such as visual field deficits and sensory deficits to touch, pain, etc. The N in Van refers to neglect, lack of attention to, and lack of awareness of one side of space, typically contralateral to a brain lesion, that is not attributable to weakness, sensory loss, or visual field loss. Neglect is also called hemispatial neglect or hemi-inattention. It is usually due to a right parietal lesion with denial of left hemispace and hemibody. The silent G in Van refers to gaze preference, deviation of both eyes to the left or right due to lack of volitional control of gaze with normal eye movements on doll's eye maneuver, often accompanied by head deviation as well. Because gaze is a motor problem, weakness of eye muscles, the lesion causing gaze preference is in the frontal lobe, specifically the frontal eye fields, anterior to the motor cortex on the side of gaze deviation. For example, a lesion in the left frontal eye field results in left gaze preference due to weakness of right lateral gaze. The right lateral rectus and left medial rectus are weak. But on doll's eye maneuver, the eyes can look to the right, and thus a gaze deviation in this case is proven to be a so-called preference. The eyes prefer to look to one direction, but they can look in the other direction if one does a doll's eye maneuver. And this tells you the lesion is in the frontal lobe, the center for voluntary control of gaze. Another unique characteristic of the cerebral cortex is the frontoparietal homunculus. Homunculus literally means little human being, but often refers to the cerebral cortex topographic organization of body control in the frontal motor and parietal sensory cortices. The frontal and parietal cortex areas that control face are inferior lateral, arm are superior lateral, and leg are medial or parasagittal. And thus, cortical lesions may result in deficits isolated to the face or arm or face and arm or leg. The final unique aspect of the cerebral cortex to help us localize a lesion there is that cerebral cortex neurons, unlike most other cells in the body, can function too much as well as too little, and therefore there are two types of lesions of the cerebral cortex. Irritative lesions, in which the neurons are hyperactive or have physiologic dysfunction, or destructive lesions, in which the neurons are hypoactive. They're anatomic or structural lesions causing dysfunction. The two physiologic conditions that cause hyperactive cerebral cortical neuronal dysfunction are seizures and migraine. Seizures are due to increased electrical activity in the brain, and there are two main categories, generalized and focal. Among the general, the most common types are tonic-clonic and generalized absence. Now, generalized absence seizures involve the entire cortex but are non-convulsive. Clinically, they look like a focal impaired awareness seizure with staring and automatisms, but without an aura postictal state. They are brief, lasting only a few seconds, and occur in childhood primarily and are rare in adults. Among focal seizures, there's focal aware, formerly known as simple partial, and focal impaired awareness, formerly known as complex partial. And sometimes a focal lesion results in focal seizures that spread to the rest of the brain. We call this focal to bilateral tonic-clonic, formerly called partial with secondary generalization. Generalized tonic-clonic seizures occur when there is increased electrical activity that starts simultaneously throughout the cerebral cortex. The first phase is the tonic phase. Tonic refers to increased tone or stiffening of the muscles. In this phase, the patient has diffuse muscle contractions with extension of limbs. The patient's jaw clenches, the limbs stiffen, back arches, abdominal muscles contract. This results in tongue biting, abnormal cry or shout, and urinary or fecal incontinence. The next phase is the clonic phase. Clonic refers to shaking of the muscles. So in this phase, the patient has diffuse rhythmic muscle contractions with shaking of the limbs, and this may result in injury to the head and limbs from striking hard surfaces. Recall that a generalized tonic-clonic seizure may start generalized or focal. A generalized onset starts with involvement of all four limbs, and no aura or focal postictal state occurs. In focal onset, the focal to bilateral tonic-clonic seizure, the patient may have an associated aura or focal postictal deficit. There are two types of focal seizures, focal aware and focal impaired awareness. Focal aware seizures, formerly known as simple partial seizures, occur when there is increased electrical activity limited to a focal part of the cortex. In this type of seizure, the patient has normal consciousness and has a focal symptom that varies based on the seizure focus location. If it's in the motor area, the patient may have limb shaking on one side of the body. If the lesion is in the parietal area, for example, the patient may have tingling on one side of the body. In the occipital area, may have lights in the vision. In the language center on the left, may have an aphasia, or may, in the temporal lobe, have a sense of deja vu. And often, there's a postictal focal deficit. In focal impaired awareness seizures, formerly known as complex partial seizures, there's increased electrical activity that starts in a focal part of the cortex, but it spreads to a part of the contralateral cortex. This results in decreased consciousness, specifically decreased awareness. Usually at the onset, there's normal wakefulness, but abnormal awareness, a subset of consciousness, manifested by blank staring. These patients often have an aura, which is a focal symptom that varies based on seizure focus location prior to the other phenomena of the seizure. The seizure, be very clear, is occurring during the aura. There's abnormal electrical activity during the aura. And these patients often have automatisms, which is automatic movements such as picking, blinking, or lip smacking that are non-purposeful. And they will have a postictal state like the simple partial seizures, but their postictal state is often associated with consciousness changes, delirium or confusion, and decreased consciousness, as well as a focal deficit. Another example of an irritative lesion in the cerebral cortex is migraine. Migraine is classified as a headache or pain disorder, but actually it involves many chemical changes in the brain. And a migraine aura is like a slow motion seizure. In the aura, a chemical chain reaction across different areas of the cortex lead to symptoms that travel in the body and progress from one to another. One can tell if a migraine aura is causing symptoms when the symptoms are transient, stereotypical, that is to say, have recurrent similar spells in genetically determined location of the cortex, when the sensory phenomena are positive initially, such as lights in the vision or tingling in the body, followed perhaps by negative sensory phenomena, such as holes in the vision called scotomata or decreased sensation, when the symptoms are traveling or migratory from one part of the body to another, such as going from the face to the arm to the leg, and or when the symptoms are progressive, meaning they progress from one type of symptom to another, such as visual to tingling to abdominal, etc. Unilateral lesions in the cerebral subcortex usually result in deficits on one side of the body contralateral to the lesion, involving the face, arm, and leg, or the arm and leg. When the lesion involves cortical spinal tract dysfunction, there is a hemiparesis, or weakness, on the opposite side. When it involves sensory fibers, sensory tracts, you have a hemisensory deficit on the other side, sensory loss on the other side. And when it involves cerebellar tracts, you have hemiataxia, or discoordination, on the other side. In the subcortex, these wires or neuronal pathways for face, arm, and leg are bundled together. So that's why subcortical lesions tend to involve face, arm, and leg equally, or arm and leg equally. Bilateral lesions in the cerebral subcortex may predictably result in spastic quadriparesis due to bilateral upper motor neuron dysfunction, but may also result in urinary incontinence due to disinhibition of frontal lobe control of the bladder, and may lead to a condition called pseudobulbar palsy, manifested by bifacial weakness, dysarthria, that's slurred speech due to weakness of the muscles of the mouth, dysphagia, swallowing problems due to weakness of the muscles of the mouth and throat, and emotional lability, also known as pseudobulbar affect. Pseudobulbar means fake brainstem, and this term was developed in the era before we had CT and MRI scans, when doctors predicted a lesion in someone who had passed away was going to be in the brainstem due to the bifacial weakness and profound dysarthria and dysphagia, and found out that actually it was in the subcortex up and higher than the brainstem. And when you had these bilateral subcortical lesions, it caused a syndrome mimicking brainstem dysfunction. Thus it was called pseudobulbar. Bulbar refers to brainstem. The three main large arteries that supply the cerebrum are the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. The anterior cerebral artery supplies the medial or parasagittal part of the cerebrum. The middle cerebral artery supplies the biggest part of the cerebrum, the superolateral part of the cerebrum. And the posterior cerebral artery supplies the inferior temporal lobe, the thalamus, and also, not seen in this image, more posteriorly, the occipital lobe. Most CT scan and MRI brain images are presented in the axial view. So looking here at the arterial distributions on an axial view, once again, one can see the anterior cerebral artery supplies the medial brain, the MCA, that larger part of lateral brain, and the PCA, in this case, the posterior occipital, maybe parieto occipital area, as well as the thalamus. There's also a small artery called the anterior choroidal artery that comes off right where the MCA and ACA branch off. There's a smaller artery that goes back called the ACA, anterior choroidal artery rather, that supplies mainly the internal capsule area. Here is a coronal view of the cerebral arteries themselves seen on normal magnetic resonance angiography. Outlined in red, the anterior circulation, and outlined in yellow is the posterior circulation. The internal carotid arteries come up on the neck. They make a right angle into the petrous bone, and then go up and make a little curve in the cavernous sinus area, also known as the siphon of the internal carotid artery, before they bifurcate into the MCA and ACA, the middle cerebral artery and anterior cerebral artery. The proximal segment of the MCA is also known as the M1 segment. The vertebral arteries posteriorly come up, and they first of all have a very prominent branch called the pica, posterior inferior cerebellar artery, and then they come and join to form the basilar artery, which goes along the brainstem, especially the pons, and at the area of the midbrain, the basilar artery bifurcates into two posterior cerebral arteries that wrap around the midbrain and supply the inferior temporal lobes, then go back into the occipital lobe. Ischemic stroke occurs when there is decreased blood flow to a focal area of the brain. And one of the more common patterns of ischemic stroke is occlusion of the middle cerebral artery, or MCA. One can tell by history and exam alone where the occlusion of the middle cerebral artery is likely to be. So recall that the MCA supplies the lateral brain, the area of the cortex that controls the arm and face motor and sensory areas. And the anterior cerebral artery supplies the medial cortex, the area for the leg control of motor and sensory functions. However, the wire or the cortical spinal tract coming from the medial cortex, from the leg, travels into the internal capsule through the MCA territory. The internal capsule is in the MCA territory. So you can actually have an MCA occlusion causing leg weakness. And if one looks more closely at this, a proximal M1 occlusion, in other words, an occlusion of the middle cerebral artery's first segment, the M1 segment, at the very, very beginning of that segment, proximal M1 occlusion, will result in face, arm, and leg weakness equally because you are getting proximally enough to get the internal capsule. A distal M1 occlusion, that is, say, a blockage that is farther down the road in the M1 segment, will avoid the internal capsule and only get the cortex. So those occlusions will result in face and arm weakness without leg weakness, or with much lesser leg weakness. Both proximal and distal M1 occlusions will result in patients being VAN positive. So these cortical findings of visual field deficit and/or aphasia and/or neglect and/or gaze preference. But it is important to recognize these two patterns, proximal M1 occlusion versus distal M1 occlusion, to predict where the embolus blockage will likely be on angiography tests. The left cerebral hemisphere is the dominant cerebral hemisphere in most people, that is to say, the side with language function. As one might predict, a left hemisphere lesion results in a right hemiparesis and/or right hemisensory loss. In addition, a left cerebral hemisphere lesion will result in a right visual field deficit, a decreased vision in the right side of both eyes. And because the left brain makes you look to the right, the left frontal eye fields make you look to the right, a left cerebral hemisphere lesion makes it hard to look to the right, so therefore your eyes are looking to the left. You have left gaze deviation. And that deviation is specifically a preference, meaning it can be overcome by Dahl's eye maneuver.
The left cerebral hemisphere lesion also will result often in aphasia, a problem with language, either expressive or receptive. Now, expressive aphasias, as said before, are more frontal, so these folks will also have commonly weakness on the other side, on the right side. And the sensory aphasias, receptive aphasias, more posterior in the brain, are more likely to be associated with sensory deficits or visual field loss. This pattern of left hemispheric dysfunction is commonly due to occlusions of the middle cerebral artery in ischemic stroke. And that's when we typically use the VAN acronym the most. So the cortex, again, is involved, that is to say the patient may be VAN positive if there is a visual field deficit or and/or aphasia and/or gaze preference, in addition to a hemiparesis involving either face and arm or face, arm, and leg. Hemisensory loss as well. The subcortex specifically, must also be involved when the leg is also very involved. And again, you can differentiate the proximal M1 versus the distal M1 based on that involvement of the subcortex. The right cerebral hemisphere is the non-dominant hemisphere in most people, the side without language. Very similarly to the left hemisphere, you get contralateral deficit. So a right brain lesion would give you left hemiparesis and/or left hemisensory loss, a left visual field deficit, and a right gaze deviation due to a preference. But instead of language or aphasia difficulty, the patient might have neglect or left hemi inattention. And once again, one can say a patient is so-called VAN positive if they have the hemiparesis involving the face and arm at least, as well as the visual field deficit, neglect, or gaze preference. Any of those three makes a patient VAN positive. And the subcortex is also involved in addition to the cortex if there's hemiparesis involving arm and leg equally. Now there may be just subcortex alone involved, involving arm and leg, and then the patient is VAN negative. None of those cortex findings would be found on history or exam. The brainstem primarily consists of primitive centers and cranial nerves. Primitive center deficits include decreased consciousness due to involvement in the ascending reticular activating system in the dorsal midbrain and pons. Nausea and vomiting due to involvement of the area postrema in the dorsal pons in the floor of the fourth ventricle. Hiccups and abnormal respirations due to involvement of the respiratory center in the pons and medulla. And then there are cranial nerve deficits. Oropharyngeal weakness is common, with resultant dysarthria, slurred speech due to weakness of the muscles of the oropharynx, or dysphagia, trouble swallowing due to weakness of the same muscles, and this is due to involvement of cranial nerves 7, 9, and 10 in the pons and medulla. One might get vertigo, a sense of a hallucination of movement, or tinnitus, ringing in the ears, with a brainstem event with involvement of cranial nerve 8 in the pons and the medulla. And one may have eye movement abnormalities, including diplopia, that's double vision, specifically binocular diplopia, where when you cover one eye, it gets better because the two eyes aren't looking at the same thing due to eye muscle weakness in neurologic diplopia. And that's the history. The exam is that you see the two eyes not looking at the same thing. That's disconjugate gaze, abnormal conjugate conjoined, so abnormal conjoined gaze. The two eyes are not looking at the same thing. This is cranial nerves 3, 4, and 6 in the midbrain and pons responsible for this. And you can have a gaze deviation, much like you can in the frontal lobe, but unlike the frontal lobe lesions, the gaze deviation in a brainstem lesion results in a palsy, meaning the eyes cannot move with Dahl's eye maneuver, cannot move with any other strong maneuver, such as cold water calorics. This is due to involvement of the horizontal gaze center in the pons. The key clinical findings in the brainstem are depressed consciousness, diplopia, horizontal gaze palsies, vertigo, and bilateral crossed signs. So as one can see in this cartoon, the ascending reticular activating system, or ARAS, is in the upper brainstem, the midbrain and upper pons. And this lesions there cause depressed consciousness. Double vision, diplopia, is caused especially when you involve cranial nerve 3 due to upper midbrain lesions, which actually give you vertical diplopia. The two images, one image is a little higher than the other, along with ptosis, eyelid droop, and mydriasis, which is an enlarged pupil. Horizontal gaze palsy's fixed gaze deviation occurs when you involve the lateral pons in the horizontal gaze center. The horizontal gaze center is actually incorporates the CN6, cranial nerve 6 nucleus. And when that is not functioning due to a mid-pons lesion, you have gaze deviation in which both eyes look to one side or the other with complete inability to move the eyes in the other direction no matter what maneuver you use. And vertigo, or hallucination of movement, occurs due to cranial nerve 8 dysfunction due to medullary lesions. And this, recall that vertigo does not necessarily mean spinning. It can mean it's moving, a sense of moving side to side, back and forth. It's a hallucination of movement. Bilateral cross signs are common. Okay, why? Because you have, remember, the brainstem is also the funnel for the wires going up and down, connecting between the cerebrum and the spinal cord. If you have a midline lesion that involves both sides, you'll get bilateral brainstem lesions, and that'll cause bilateral face and or limb signs. And we talked about this in the setting of pseudobulbar palsy. However, if you have a unilateral brainstem lesion, they cause ipsilateral face and contralateral body signs. We call that crossed, one side of face, other side of body. Since cranial nerves innervate the ipsilateral head and the brainstem long tracts serve the contralateral body. This slide visually demonstrates the bilateral brainstem lesion and unilateral brainstem lesion findings regarding the long tracts. So on the left, the bilateral brainstem lesion gives you bilateral long tract signs. So you get quadriparesis, sensory loss on all four limbs, but also face and head involvement. Unlike, for example, a cervical spinal cord lesion would give you quadriparesis and sensory loss on all four limbs, would not involve the face and head. A unilateral brainstem lesion, again, gives you involvement of the ipsilateral face and contralateral body. And you have a hemiparesis or hemisensory loss that only involves arm and leg and not face on one side, whereas the ipsilateral face has the deficit, either weakness or sensory loss. The most common ischemic stroke syndrome that involves the brainstem is the lateral medullary or Wallenberg syndrome. In this syndrome, the involvement of the lateral medulla leads to decreased face pinprick sensory loss on the ipsilateral side and contralateral body or pinprick loss. In other words, crossed sensory loss to pinprick and temperature. You also have ipsilateral Horner syndrome, ipsilateral hemiataxia, and very prominent vertigo, nausea, dysphagia, and hoarseness in some people. The reason for these various clinical findings and the structures responsible for them are in a table on this slide. The cause of lateral medullary or Wallenberg syndrome is usually due to an embolic occlusion of the posterior inferior cerebellar artery. And this embolus is most often, but not always, due to large artery atheroembolism from the vertebral artery or cardioembolism. The key clinical findings in the cerebellum are limb and gait ataxia. Ataxia means abnormal coordination of a limb, trunk, or gait. The muscles are not speaking with one another. When you want to move a muscle, you would not like the opposing muscle to contract at the same time. And the cerebellum takes care of that for you. It enables you to have only the muscle you want to contract. When the cerebellum's not working, then the muscles fight each other and you have a discoordination of the limb or gait. The cerebellar hemispheres are ipsilateral to the body side that they control. Cerebellar hemisphere lesions cause ipsilateral limb ataxia. The cerebellar midline lesion involves truncal or gait ataxia, imbalance with a wide-based gait. Now, the reason, just so you know, why the cerebral hemisphere lesion causes ipsilateral limb ataxia is because it is controlled by the opposite side of the brain. The cerebellum controls the same side of the body because cerebral cortex controls the opposite side of the cerebellum. In neurology, the term gaze refers to yoked eye movements, so movements of both eyes together. Diplopia means double vision. Normal gaze is conjugate. Both eyes are conjoined in their movements. Gaze deviations, palsies, and preferences are asymptomatic, actually, since gaze remains conjugate. Both eyes are still looking at the same thing. Neurologic diplopia is always due to disconjugate gaze. The eyes are looking at two different things. And diplopia is always of sudden onset. So it's redundant to say sudden onset diplopia. Diplopia is always sudden. Diplopia or double vision can be monocular or binocular. Monocular diplopia refers to double vision that occurs with one eye open. The closing one eye, the asymptomatic one, does not resolve symptoms. So you only have double vision in that one eye, binocular. This is almost always due to an eye problem, retina, lens, cornea, etc., and is not neurologic and not what neurologists deal with. However, binocular diplopia is always neurologic. This is double vision that occurs only with both eyes open, and closing one eye, either one, does resolve the symptoms. It's due to extraocular muscle weakness. And the exam finding is disconjugate gaze. Now notice that patients with chronic disconjugate gaze, called strabismus, do not have diplopia because over time the brain suppresses one of the images. There are 6 cardinal positions of gaze due to the actions of 6 extraocular muscles. The lateral rectus muscle is responsible for abduction, moving the eye out. The medial rectus is responsible for adduction, moving the eye in. The superior rectus is responsible for making the eye look up when it is already out. The inferior oblique is responsible for making the eye look up when the eye is already in. And the inferior rectus is responsible for making the eye look down when the eye is out. And the superior oblique is responsible for making the eye look down when the eye is in. If you notice, the lateral rectus is controlled by cranial nerve 6, the superior oblique is controlled by cranial nerve 4, and the other muscles are all controlled by cranial nerve 3. Right gaze then, looking at the bottom of the page here, right gaze occurs when the right lateral rectus and left medial rectus contract. Left gaze occurs when you have the left lateral rectus and right medial rectus contract. On right up gaze, the right superior rectus is contracting and the left inferior oblique. On left up gaze, the left superior rectus is contracting and the right inferior oblique is contracting. In right down gaze, the right inferior rectus is contracting and the left superior oblique is contracting. And on left down gaze, the left inferior rectus is contracting and the right superior oblique. The 2 main areas for control of horizontal gaze are in the frontal eye fields and horizontal gaze centers. The frontal eye field is responsible for upper motor neuron control in the frontal cortex and controls only volitional gaze. It controls gaze to the opposite direction. It does so by stimulating the horizontal gaze center in the contralateral pons. The horizontal gaze center is the lower motor neuron control center in the pons. It consists of both the paramedian pontine reticular formation, PPRF, and cranial nerve 6 nucleus. It controls gaze to the ipsilateral direction by stimulating the ipsilateral cranial nerve 6, making the lateral rectus contract, and the contralateral cranial nerve 3 via the MLF, the medial longitudinal fasciculus. This goes from the horizontal gaze center and it crosses over to the opposite medial rectus nucleus within the cranial nerve nuclei for 3, cranial nerve 3, and makes the medial rectus contract.
So once again, gaze deviation may be due to gaze preference or gaze palsy. Let's look at an example of left gaze deviation. Both eyes are looking far to the left. One must figure out if this is a frontal lobe problem or a pontine problem. A left gaze preference is due to a left frontal or frontal eye field lesion. In this case, when you perform the doll's eye maneuver or oculocephalic maneuver, the patient's eyes can look to the right. On the other hand, if someone has a right gaze palsy, they have a right pontine lesion in the horizontal gaze center. And on doll's eye maneuver, the eyes cannot look to the right at all. They cannot move, even with the doll's eye maneuver. So thinking it through for a second, the left gaze deviation is either due to a left gaze preference in the left frontal lobe or a right gaze palsy in the right pons. Notice that the preference is named by the direction the patient can look, and the palsy is named by the direction the patient cannot look. However, the way to remember this is a left preference is a left frontal problem. A right palsy is due to a right pons problem. The most common cranial nerve palsy is cranial nerve 6 or abducens nerve palsy because there are three distinct pathologic processes that may lead to cranial nerve 6 dysfunction. Let's start by reviewing the anatomy. Cranial nerve 6 nucleus is in the pons, and the cranial nerve 6 leaves the pons anterolaterally, then runs up the meninges along the clivus behind it. The clivus is bone, and then takes a right angle into the cavernous sinus before proceeding into the orbit and controlling the lateral rectus. Stretching of cranial nerve 6 can occur as it turns into the cavernous sinus due to head trauma. The deceleration injury, when you accelerate, decelerate, you stretch at that right angle where arrow A is and can cause 6th nerve palsy. Also, the 6th cranial nerve is the only cranial nerve that runs along a bony prominence. So it runs up the clivus, and increased intracranial pressure will compress the 6th nerve against that bony clivus, causing, again, a 6th nerve palsy. All cranial nerves exit the central nervous system via the meninges, through the meninges, and therefore inflammation of the meninges, meningitis, can cause inflammation of a cranial nerve, including cranial nerve 6, and a 6th nerve palsy. So really it's because of both the fact that 6th nerve is running along the clivus, first of all, prone to increased ICP, and takes a right angle into the cavernous sinus, making it prone to stretching, are the two reasons why people often will have horizontal diplopia after head trauma or after in association with increased ICP. Another possible cause of horizontal diplopia is internuclear ophthalmoplegia, or INO, so named because the lesion is between the nuclei of cranial nerve 6 and cranial nerve 3. And in other words, involves the medial longitudinal fasciculus, or MLF. Now, the MLF is a long, thin, myelinated wire connecting, or axon, connecting cranial nerve 6 to cranial nerve 3, the medial rectus component of cranial nerve 3. And it actually is much longer than depicted in this cartoon, but the section between cranial nerve 6 in the pons and cranial nerve 3 in the midbrain is what we care about right now. Because it is in the middle, and the arteries coming off the basal artery, tiny little perforators come in the middle off the paired perforators come off the basal artery. They are prone to infarctions due to especially small vessel disease. And because they are myelinated, they are prone to demyelinating diseases such as MS. So by far the most common causes of INOs are either ischemic stroke or MS. In a patient with an INO, when, for example, a right INO, a patient looking to the left the left eye looks normally to the left. but the right eye cannot look in. The right medial rectus is not connected anymore. There's disconnection between cranial nerve 6 and cranial nerve 3. So when you say look left to your pons, the pons says, okay, cranial nerve 6, move that lateral rectus out, but the medial rectus can't follow. Now, in these circumstances, there's often nystagmus of that eye looking out, as if it knows that the medial rectus is not following it, and it's trying to overcome it. These folks with INOs can move their medial rectus on convergence, because convergence does not require any involvement of the pons and the MLF. The control for that goes directly to the back of the midbrain and just works with the cranial nerve 3 alone. So people with INOs, let's for example, a right INO, the diplopia is binocular, gets better if you close one eye. It's horizontal. It's worse on the left gaze in a right INO, okay, with left eye nystagmus. And it'll be the same near and far. There's normal convergence, so there's no difference in the diplopia near or far. Cranial nerve 3 palsies are important to recognize, and there are two main pathophysiologic processes that cause cranial nerve 3 palsy: infarction and compression. Let's first review the anatomy. As you know, the oculomotor nerve has both the oculomotor component, the motor component, and the parasympathetic component, the Edgar-Westphal component. The parasympathetic axons actually run outside the oculomotor axons, much like a beret on the outside, and have a different arterial supply. So, infarction of the cranial nerve 3 results in oculomotor palsy with ptosis, ophthalmoplegia, vertical diplopia, but spares the pupil. The most common cause of this is diabetes, causing microvasculature changes that lead to infarction of the third nerve. Diabetic third nerves spare the pupil. Infarctions of the third nerve have normal pupils, despite the fact they have ptosis and ophthalmoplegia. On the other hand, compression of cranial nerve 3 results in compression of both the oculomotor component and the parasympathetic component. So both oculomotor palsy occurs with ptosis, ophthalmoplegia, and double vision, and mydriasis, an enlarged pupil. The most common reason to compress the third nerve is a posterior communicating artery aneurysm. When localizing a lesion in a patient with horizontal diplopia, that is to say double vision in which images are side by side, one must first determine which muscle is weak. Is it a lateral rectus or a medial rectus, and which side? And there are specific questions to ask. Are the images farthest apart to the right, to the left, far or near? Let's look more carefully. If the double vision is worse on right gaze, then the problem is either the right lateral rectus or the left medial rectus. How do you tell the difference? Well, it depends. Ask the patient, is the double vision worse? In other words, images farther apart when you're looking in the distance, far, or near, such as when reading, or are they the same near and far? If the images are worse on far vision, it's a right lateral rectus problem, and therefore almost always a right cranial nerve 6 palsy. If the images are worse on near vision, that means you have an isolated medial rectus problem that persists even with looking at near objects, even when converging. That does not happen from a cranial nerve 3 problem. So that's an isolated medial rectus problem at all times. Therefore, that's going to be most likely something else, like a myasthenia gravis, a neuromuscular junction problem. If the images are same near and far, then it's actually a left INO. The left medial longitudinal fasciculus has been damaged. If the images are worse on left gaze, everything's the opposite. It's either a left lateral rectus or a right medial rectus problem. You ask the same questions. Is it worse far? That'd be a cranial nerve 6 problem. Worse near, myasthenia for the right medial rectus, or same near and far, right INO. Depressed consciousness is a syndrome of decreased wakefulness or awareness. Those are the two components of consciousness, wakefulness and awareness. It is due to dysfunction of the ascending reticular activating system, the ARAS, through either one of two mechanisms, either bicerebral dysfunction involving both thalami or both diffuse frontoparietal cortices, or brainstem dysfunction. Bicerebral dysfunction has many possible causes: toxic encephalopathy, metabolic encephalopathy, increased intracranial pressure, acute concurrent bicerebral lesions, physiologic phenomena such as seizure, postictal state and migraine, and hypotension. Whereas brainstem dysfunction is usually a focal neurologic problem, focal things such as strokes or masses. So, when attempting to localize a lesion in a patient with depressed consciousness, one must always first determine, is it brainstem dysfunction or bicerebrum dysfunction? Which one is it? The ascending reticular activating system is involved in both cases. The ARAS, or consciousness center, is in the upper brainstem, midbrain and upper pons, and hypothalamus, and basal forebrain. It's innervated by the lateral hypothalamus and diffusely innervates and stimulates both thalami and the frontoparietal cortices. Inhibition causes decreased consciousness by either direct brainstem dysfunction, a focal lesion we talked about, structural such as stroke or mass, or bicerebral dysfunction, which is diffuse or multifocal lesions, often physiologic, especially toxic or metabolic encephalopathy. Remember another thing, that brainstem mainly affects wakefulness and bicerebrum mainly affects awareness. The key to localizing whether a lesion that causes depressed consciousness is in the brainstem or bicerebral are the eye movements. The dorsal upper brainstem contains both the ARAS and cranial nerves 3, 4, and 6, all of which control the eye movements. Therefore, in patients with depressed consciousness, eye movements help localize the lesion. Brainstem lesions will have abnormal eye movements. Bicerebral dysfunction will result in normal eye movements. Now, the exception to the rule may be increased intracranial pressure or head trauma that leads to an isolated 6th nerve palsy. But if there's only isolated lateral rectus weakness, that's not the same. That's not a localizing sign that's helpful. But in general, otherwise, eye movements that are abnormal tell you the lesion is in the brainstem causing depressed consciousness. Myelopathy is a term we use for spinal cord diseases. Myelo means spinal cord, diseases, pathies. The key clinical findings for a myelopathy are weakness, sensory loss, urinary incontinence, constipation, and sexual dysfunction. The weakness comes in the pattern of a quadriparesis or paraparesis. Quadra means all 4 limbs, paraparesis means just the legs. And of course, this is determined by where the lesion is in the spinal cord. If the lesion is high in the cervical region, you involve arms and legs. If it's below the cervical region, thoracic and lower, it might only involve the legs. When somebody has absolutely no movement whatsoever, we call it a plegia. So you can say quadriplegia if there's no movement at all. Paraplegia, no movement at all in the legs, for example. Acutely, the spinal cord lesion may result in decreased reflexes, but that's only for a short period of time. Within a few hours to days, patients with spinal cord will have a classic upper motor neuron finding of increased reflexes and Babinski signs. The sensory loss in myelopathy is usually a sensory level. It specifically refers to a level somewhere on the thorax, below which there is no sensation or decreased sensation, and above which there's normal sensation. Let's say sensory level, typically in the thorax. We're not talking about in the feet, but in the thorax. And because of the way the pain and temperature fibers are separated from the vibration and proprioception fibers, you can have, depending on the pathology, a separation of these. You can have a sensory level to all modalities. You can have a sensory level to just vibration and proprioception, or a sensory level to pain and temperature. Urinary incontinence is another big symptom. And again, acutely, it might seem like a lower motor neuron problem with hypotonic large bladder, but within a few hours to days, it's going to be a chronic problem. It's going to be an upper motor neuron bladder with a small spastic bladder. Hesitancy, urgency, frequency, small volumes. And the bowel problem that these patients have is constipation, not incontinence, when you have a spinal cord problem. And sexual dysfunction is a very important symptom they can get. Men, of course, erectile dysfunction, and women, anorgasmia. So it's quadriparesis or paraparesis, sensory level, and the 3 autonomic dysfunctions: urinary incontinence, constipation, sexual dysfunction for a myelopathy. In trying to find out where in the spinal cord the lesion is, look for the sensory level on history as well as on exam. On exam, it's decreased sensation at or below the lesion level, history or exam. But also, patients often have a tight belt sensation at the lesion level by history, and that helps you a lot. There also are reflex levels. So, in other words, normal reflexes above the lesion and it usually increased reflexes below the lesion, maybe acutely decreased, but chronically increased. Sometimes a lesion compresses a nerve root at the end of the spinal cord at the same time. So one might have a radiculopathy at the level of the lesion and a myelopathy below the lesion. For example, if someone has pain shooting down their arm into their thumb and at the same time has decreased reflexes in the brachioradialis and biceps, but has increased reflexes below that and at sensory level at around C6, they have a myeloradiculopathy at C6. The lesion must be at C6. The lateral sign, the horizontal sign, is C6. The vertical sign is the spinal cord symptoms of the sensory level. Lermite sign is a shock-like sensation down the back with passive neck flexion. And it suggests something's going on in the dorsal or posterior columns, especially in the neck, cervical, posterior column. So any lesion that involves the posterior columns in the cervical region will give you Lermite sign. Radiculopathy is dysfunction of a nerve root. Dermatome is sensory distribution of an individual nerve root, and dermatomal pattern is a strip of skin correlating to a specific nerve root distribution. The three key clinical findings in radiculopathy are radiating pain and sensory loss, weakness, and reflex decreases. Radiating pain and sensory loss in a dermatomal pattern. By history, ask, where does the pain end? Determine where the pain ends. And on exam, test pinprick, only pinprick, that's the sensory deficit you need to test, in the middle of the dermatome. Looking at the cartoon to the right here, the various dermatomes, the middle of those dermatomes are labeled. And that's where you need to ask regarding pain radiation and where you test with your pin. Let's give an example. If somebody has a C7 radiculopathy, they will say the pain radiates into the middle finger. You cannot be happy with when somebody says, oh, the pain radiates into my arm. That is not good enough. You must clarify. Well, does it radiate into the middle finger or the thumb or the pinky? Where? If they say middle finger, you know it's C7, and then you test C7 with your pinprick. They should also then have weakness in that area. If it's been there long enough, usually a few weeks, they might have atrophy and fasciculations, a lower motor neuron pattern of weakness involving those muscles. For example, the triceps muscle is innervated by C7, so they might have weak triceps muscle. They would also have decreased reflexes or absent reflexes in the same dermatomal distribution. So in patients, for example, the C7 radiculopathy, they would have a decreased triceps jerk in that area. Cervical and lumbosacral radiculopathies are more common than thoracic radiculopathies and are especially due to nerve root compression by either a herniated disc or an osteophyte. Plexopathy refers to disease or dysfunction of a plexus, a grouping of different nerve roots that come together and then separate again to form nerves. The brachial plexus in the arm consists of nerve roots C5 through T1. Notice that in the brachial plexus, most of the nerve roots, come out of the vertebrae above the correspondingly named vertebra. So C5 comes out above C5, C6 above C6, C7 above C7. However, because there are only 7 cervical vertebrae and 8 cervical nerve roots, C8 starts the process whereby nerve roots come out below the correspondingly named nerve root. C8, there is no corresponding vertebra, but T1 comes out below T1. In the brachial plexus, the nerve roots all share some fibers as depicted here to form various nerves that go to the arm. The musculocutaneous, the axillary, the median, the radial, and the ulnar are the major nerves in the arm. And their corresponding nerve roots are depicted along with that. When somebody has weakness, sensory loss, and pain, these plexopathies are commonly painful. Weakness, sensory loss, and pain in the arm involving more than one nerve. Think about the possibility that it is a plexopathy, a brachial plexopathy. The most common reasons are trauma or compression. It can be compression from a tumor infiltrating the axilla. It can be from trauma. For example, if someone has a broken leg and uses crutches the wrong way, the crutch can compress the brachial plexus in the armpit, for example. So these are the major reasons. Or you can have a stretching of the arm and a stretching injury, farming accidents, things like this can happen. So this is how you get a brachial plexopathy. The lumbosacral plexus consists of nerve roots L2 through S2. And like the precedent set by C8 above in the brachial plexus, these nerve roots come out beneath the correspondingly named vertebra, L2 below the vertebra L2, etc. These nerve roots come together to form the major nerves in the leg: the femoral nerve, the obturator nerve, the sciatic nerve, and its two branches, the peroneal nerve and the tibial nerve. The corresponding nerve roots are adjacent to the names of the nerves on this slide. Just like in brachial plexopathy, a lumbosacral plexopathy presents with weakness, sensory loss, and pain in a leg, this time not in the arm, involving more than one nerve. In general, if a patient has weakness, sensory loss, and pain in a limb that does not correspond to a clean, pure radicular pattern and is involving more than one nerve, think plexopathy. The most common reason for a lumbosacral plexopathy is invasion by cancer, though both the brachial and lumbosacral plexus may be affected by inflammation, autoimmune disease as well. The term neuropathy refers to involvement of peripheral nerves, but is an otherwise nonspecific term that includes three different patterns or categories of disease. A mononeuropathy is dysfunction of one individual nerve, and it is often due to compression of that nerve. Mononeuropathy multiplex is dysfunction of multiple individual nerves, usually due to either an infarction of those nerves, due to for example, small vessel vasculitis that infarcts the nerves, or inflammation of the individual nerves. And the term peripheral neuropathy is very specific, actually, also known as polyneuropathy. Those are equivalent terms, peripheral neuropathy and polyneuropathy. These are dysfunction of distal nerves diffusely and symmetrically. And it is due to a systemic condition, including certain metabolic, toxic, autoimmune or inflammatory, and genetic conditions. Peripheral neuropathy or polyneuropathy is diffuse, distal, symmetric nerve dysfunction that can be motor or sensory or both due to various systemic conditions, such as metabolic conditions, the most common of which would be diabetes mellitus and B12 deficiency, or toxic conditions such as alcoholism and chemotherapy, autoimmune disease, or genetic diseases. One can have pathology in the axon or the myelin of these nerves, and different diseases cause problems with different locations on the nerve. In general, people with peripheral neuropathy, the key clinical findings will be decreased reflexes, hypo or areflexia, diffusely on exam, and distal sensory loss, perhaps associated with neuropathic pain. The distal sensory loss can involve only vibration and proprioception or pain and temperature or both, because there are different nerve fibers serving each. The large nerve fibers serve vibration and proprioception. The small nerve fibers serve pain and temperature. So you can have a large fiber peripheral neuropathy or a small fiber peripheral neuropathy or mixed. In general, these metabolic and toxic and other conditions affect the longest nerves first, and the longest nerves in the body are in the legs and the feet, actually. So they commonly get involvement of the feet. We call this stocking distribution sensory deficit. The arms, the nerves to the hands and the arms are the second longest nerves, and so the second most common distribution is glove distribution. It's most common to say that the peripheral neuropathy causes a stocking glove distribution sensory loss, although legs, the feet, are more in common than the hands, actually. There's actually a third potential pattern, and that's shield distribution. It's even less common than the glove, but it's because the nerve roots out of the thorax, they come out of the thorax and they serve the front of the chest, and that when you have sensory loss in that distribution, it's shield. So a very profound sensory peripheral neuropathy might give you stocking, glove, and shield sensory loss. Neuropathy in general, peripheral neuropathies, may be associated with neuropathic pain, discomfort of tingling or discomfort of burning, etc., in the feet especially, but maybe feet and hands, etc. Myasthenia is the term we use for disease of the neuromuscular junction. The key clinical findings are proximal symmetric weakness, normal sensation and reflexes, fatigability, ocular weakness, and oral and facial or so-called bulbar weakness. The proximal symmetric weakness is sometimes known as hair, chair, and stair weakness. Difficulty raising your arms to groom your hair, difficulty rising from a chair, and difficulty going upstairs. Of course, it's only involving the neuromuscular junction, so sensation and reflexes are normal. Fatigability is key in diagnosing myasthenia. That means the patient is worse with exertion. Their weakness is more obvious at the end of the day, or after exercising a while, or after walking for a while, after chewing for a while, etc. Ocular weakness is pretty common in these folks, so they can have double vision and ptosis that doesn't fit a true cranial nerve pattern, and that might be due to myasthenia, especially if it's fatigable muscle weakness in the eyes. Double vision occurs at the end of the day. And they can also have similarly weakness of facial muscles and swallowing muscles. So they get nasal speech, dysarthria, dysphagia, chewing difficulty, eye closure, and face weakness, especially at the end of the day or when tired. The possible causes include myasthenia gravis, in which there is a postsynaptic muscle acetylcholine receptor antibody due to autoimmune disease, or Lambert-Eaton myasthenic syndrome, known as LEMS, which is due to a presynaptic axon antibodies to the paraneoplastic syndrome. Myopathy refers to disease of muscle, muscle-pathy disease. The key clinical findings are similar to myasthenia with one major difference. Like myasthenia, people with myopathy have proximal symmetric weakness, so-called hair, chair, and stair weakness. Like myasthenia, patients with myopathy will have normal sensation and reflexes in general, though there is a type of myopathy in which one has decreased or absent reflex. That's hypokalemic periodic paralysis. The most important differentiating factor between a myasthenia and a myopathy is fatigability. Myopathies do not have fatigability, no fatigability. It is not worse with exertion. These patients' weakness is not worsened with exertion, unlike in myasthenia. Some myopathies, not all, may be associated with myalgias, muscle aches and pains. Possible causes of myopathy include polymyositis, dermatomyositis, muscular dystrophies, hypo or hyperthyroidism, drug-induced myopathy, especially steroids, and hypokalemic periodic paralysis. Visual loss involves dysfunction anywhere along the visual pathways, from the eyes to the occiput. Let's look at the visual pathways and specific lesions along the visual pathways and how they correspond to visual field deficits. Note, first of all, that ophthalmologists depict visual fields as if the patient is staring into the page or screen, so left is on the left and right is on the right, unlike radiologic images. To make things clear, the visual pathways on the left here are also organized that way, as if you're looking at the top of someone's head, and left is on the left and right is on the right. So let's first note that the outer vision, the temporal fields, actually project onto the inner retina, and the inner fields, nasal fields, project onto the outer retina. This has a direct effect, especially on what happens at the chiasm, which we'll get to in a moment. So let's start with a lesion in the optic nerve, the right optic nerve, labeled with N. If you have a right optic nerve problem, you have a right monocular deficit, as depicted in the visual fields here. If you have a lesion in the chiasm, most of these lesions are in the center of the brain and either compress the chiasm from below or above. So the patient will get selective involvement of those fibers that are more medial. And if you'll notice, once again, those medial fibers actually are those that serve the temporal fields. So a patient with a chiasm lesion usually results in a bitemporal hemianopsia. A lesion in the right parietal radiation, which is superior to the temporal lobe, will lead to an inferior quadrantenopsia on the left. And a superior occipital lesion on the right also will lead to a left inferior quadrantenopsia. The temporal radiations, however, when involved, will result in a contralateral, in this case left, superior quadrantenopsia. And the inferior occipital lobe likewise will give you a contralateral superior quadrantenopsia. If I involve both the parietal and temporal radiations together on the right, you'll get a left homonymous hemianopsia. If I involve the occipital lobe, both upper, superior, and inferior part of it, you'll get a left homonymous hemianopsia. Notice that we've not talked much about the optic tract or the lateral geniculate body. That's because lesions there are exceedingly rare, and a non-neuro-ophthalmologist should not worry about those areas at all. An important and relatively common cause of monocular visual loss is retinal artery ischemia. The anatomy of the retinal artery helps explain why it's relatively common. The ophthalmic artery comes off the internal carotid artery, usually in the siphon or cavernous sinus area. And the central retinal artery takes off directly from the ophthalmic artery at a minimal angle, making it susceptible to emboli. The central retinal artery then divides into superior and inferior branches in the optic cup, where it supplies the retina. Retinal artery occlusions cause sudden, painless, very important, painless monocular visual loss. They are almost always due to embolism, and they may occur in either the central retinal artery or a branch retinal artery. Here let's look at the visual field deficits of patients with central retinal artery occlusion, CRAO, and branch retinal artery occlusion, BRAO. Most patients who have a central retinal artery occlusion will have a complete monocular visual loss in that eye. On the other hand, branch retinal artery occlusions result in either altitudinal or wedge-shaped deficits, depending on where the embolus occluded the artery. In the cartoon on this slide, an embolus is in that superior-nasal branch. That leads to the wedge-shaped deficit, the inferotemporal deficit seen in the bottom cartoon on the right. However, if the embolus had stopped to include the entire upper branch of the retinal artery, the patient would have an inferior altitudinal defect. The only way to get an altitudinal defect, where in other words you have complete loss of vision on both sides below a certain line or above a certain line, is retinal ischemia, because the retinal artery, strangely enough, bifurcates up and down, a superior branch, inferior branch, not left and right. Left and right deficits are more often from the brain. Up and down deficits, more likely retinal artery itself. On fundoscopy, you may see the embolus occluding the artery. It often appears white, made of either platelet, clot, or cholesterol. And these patients often have a relative afferent pupillary defect. Monocular visual loss can also occur due to dysfunction of the optic nerve, cranial nerve 2. The optic nerve is an extension of the retinal ganglion cells and part of the central nervous system. It is the afferent limb of the pupillary light reflex. Recall that cranial nerve 3 is the efferent limb. Disease of the optic nerve is called optic neuropathy. And one must consider the anatomic considerations to understand the pathologic consequences. So first of all, the optic nerve is supplied by the posterior ciliary artery, and this is prone to ischemia. When this ischemia occurs, it's called AION, anterior ischemic optic neuropathy. The optic nerve is myelinated, therefore demyelinating diseases can cause optic neuritis. The optic nerve is surrounded by meninges. Therefore, it's prone to increased intracranial pressure, causing pressure on the optic nerve and damage, and this is called papilledema. And of course, the optic nerve emanates from the globe itself, the eye globe. And the eye can have increased pressure within it. Intraocular pressure can increase. That's called glaucoma. And when glaucoma occurs, it compresses that front head of the optic nerve and causes visual loss. The three key clinical findings for optic neuropathy are visual loss, abnormal optic disc, and pupillary light defect. The visual loss is, of course, monocular on the side of the cranial nerve 2 lesion. And when due to optic neuritis, there is pain on eye movement 90% of the time. The optic disc may be abnormal in different ways. It may be swollen or atrophic, or there may be cupping within the optic disc, depending on the duration of the condition and the actual condition itself. The pupillary light defect refers mainly to a relative afferent pupillary defect, known as an RAPD, or Marcus gun pupil, that is determined on the swinging light test. Let's look at the swinging light test, in which we're trying to detect a left RAPD. A person we suspect has a left optic nerve disease or dysfunction. When looking at the patient without light stimulation, both pupils are normal size. When light is shined in the right eye, the good eye, both pupils constrict normally because the sensory input into the right eye is normal and the motor control of pupils on both sides is normal. However, if you, without taking the light away too long, you just swing the light, that's why it's called swinging light test, swing the light from the good right eye to the bad left eye, paradoxically, both eyes dilate. Why? Because the left eye sensory input due to the optic nerve dysfunction is not normal. So neither eye knows there's light when you put the light into the left eye. This is called a left RAPD. R because it's relative. If you had just shown light into the left eye directly, it might be partially damage the optic nerve, and therefore the pupils would have constricted. But when you compare it to the normal right eye, swinging it from the right eye to the left eye, the amount of constriction is less. And so the two pupils dilate when you swing the light from the good right eye to the bad left eye, a relative afferent pupillary defect in the left eye. Optic nerve head edema, or a swollen optic disc, occurs for multiple different reasons. The two main subtypes of optic nerve head edema are papilledema and papillitis. The term papilledema does not refer to all examples of optic nerve head edema. One cannot call it papilledema unless you know that the optic nerve head edema is due to increased intracranial pressure. In most cases, almost always in fact, papilledema will be bilateral. And in almost all cases, papilledema will be associated with normal visual acuity because compressing the optic nerve may result in loss of some peripheral vision, but central vision is intact until the end stage of papilledema, when in fact the optic nerve no longer looks swollen, it looks pale. So once you have a swollen disc in papilledema, you still have normal visual acuity. The etiologies for papilledema include a mass lesion within the head, hydrocephalus, idiopathic intracranial hypertension, cerebral vein thrombosis, and hypertensive encephalopathy. There are other possible reasons for increased ICP. Papillitis refers to inflammation or infarction of the nerve head. It is almost always unilateral at first. It may become bilateral if the disease spreads, but it's usually unilateral starting with, and it's almost always associated with abnormal visual acuity. Etiologies include optic neuritis, inflammation of the optic nerve. This can be due to multiple sclerosis, neuromyelitis optica, MOG antibody disease, lupus, sarcoid, syphilis, Lyme, virus, and other causes. Or ischemia to the anterior part of the optic nerve, anterior ischemic optic neuropathy, which occurs both due to arteritis and giant cell arteritis, and non-arteritic forms due to usually hypotension with in essence, watershed stroke to the eye. Central retinal vein occlusion and early Leber hereditary optic neuropathy may also cause a swollen optic disc. On this slide, you see a normal optic disc on the left and a swollen on the right. And guess what? You can't tell if this is papilledema or papillitis without knowing something else about the history. If you know more about the history of your exam, you can call it papilledema or papillitis, such as, is it bilateral? Is there a visual acuity loss? And what else is going on with this patient? The location of a lesion causing headache is almost always the meninges. The meninges are a three-layered sac surrounding the brain, brainstem, and spinal cord, and pain nerves line the meninges, not just the trigeminal nerve in the face, but also cervical nerve roots in the back of the head and neck, thoracic nerve roots in the chest, and lumbosacral nerve roots in the legs. Pain nerves in the meninges are turned on when the meninges are stretched, or irritated, or ischemic, or sensitized. So, in general, most headaches are due to meningeal nociceptor or pain receptor stimulation. Stretching of the meninges via either increased intracranial pressure or decreased intracranial pressure can do this. Irritation of the meninges with white cells, that is to say meningitides, whether they're bacterial or aseptic meningitides, and with red cells, that is to say subarachnoid hemorrhage, can cause headache. Ischemia to the meninges, which occurs selectively in the condition giant cell arteritis, known also as temporal arteritis, that occurs only in elderly folks. And sensitization of the meninges when you have nociceptor agonist stimulation, usually by CGRP, calcitonin genolytic peptide, in patients who have medication overuse headaches or other primary headache disorders such as migraine or cluster. Sometimes people have head pain that maybe the doctor would not call headache, would call pain, but the patient might call headache. And so you can have head pain nerve dysfunction in patients with carotid artery dissection, vertebral artery dissection, or trigeminal neuralgia that a patient may consider a type of headache. Dizziness is a very non-specific, non-localizable term often used by patients and even by some physicians. This is, in essence, a chief concern that must be translated into a syndrome before one can go through the SADE syndrome anatomy diagnosis etiology process to figure out what's going on. There are four main syndromes that one may mean by the term dizziness: lightheadedness, vertigo, motor ataxia, and sensory ataxia. Lightheadedness is due to hypoperfusion of the brain. In other words, near syncope. In this case, the patient feels like they're about to faint. Causes are mainly non-neurologic, but there are some neurologic causes. So hypovolemia, left ventricular outflow obstruction, cardiac arrhythmias, excessive blood pressure medication, and neurogenic syncope, known as vasovagal, can do it. Dysautonomia, however, due to neurologic disease, either by a neurodegenerative disease or by a neuropathy or by migraine. Because migraine can cause transient dysautonomia with syncope or near syncope. The other type of dizziness is vertigo. Vertigo specifically means hallucination of movement. Most people think it means spinning. Not necessarily. The hallucination may be side to side, back and forth, or spinning. It doesn't matter. Those are all examples of vertigo. And this can be due to vestibular dysfunction, due to lots of things. The lesion localization can be in the ear, cranial nerve 8, the brainstem, cerebellum, or even the temporal lobe. So-called peripheral vertigo is really not, peripheral is not the right term. It's a specific type of peripheral. It's when there are misplaced otoliths or earrocks in the ear itself. When you have this condition, the vertigo will resolve absolutely completely when the patient is stationary and only occurs when moving the head. In general, other types of vertigo will continue to some degree. They all get worse when you move your head, but all will continue to some degree when you're not moving your head. Motor ataxia refers to cerebellar ataxia or discoordination. This is when a patient has gait imbalance without vertigo, unaffected by vision, and tends to fall to one side or the other. So a patient may say, I'm dizzy, when they really mean they have gait imbalance. And they tend to fall to the side of the lesion if they have a cerebellar lesion. The lesion is usually in the cerebellum or cerebellar tracts and peduncles. There's another kind of ataxia called sensory ataxia, which really is a proprioception deficit, but the patient will have the same kind of gait imbalance without vertigo that a patient with cerebellar problems have. But the difference is that their deficit gets better with vision, or maybe worse in dark. So in other words, they tend to fall when they get to go to the bathroom at night, or fall in the movie theater, or fall when they close their eyes in the shower. Those are the times. Otherwise, they're okay. Why? Because they're using their vision to overcome their proprioception deficit. Vision does not overcome a cerebellar deficit. So when the ataxia improves, the so-called dizziness, this gait imbalance improves by looking at things, but the light's on and looking at things, it is a sensory ataxia. The most common reasons for a sensory ataxia are a large fiber peripheral neuropathy, such as occurs with B12 deficiency, and diabetic neuropathy has a combined, often large and small fiber, so they often have proprioception deficit, or posterior column deficits, posterior spinal cord, from a spinal cord lesion, transverse myelitis, or maybe B12 deficiency involving the cord, subacute combined degeneration that occur in that condition, or in tabes dorsalis in people who have neurosyphilis. This is the end of this presentation, a production of DLG Insight, innovative neuroscience ideas and thoughts on education.